Good afternoon. Welcome to a discussion on hypertension and PVD, care of patients with hypertension and peripheral vascular disease. So let's talk a little bit about hypertension, things that you need to know. High blood pressure or hypertension is persistently high pressure in the arteries, and often there is no cause for the high blood pressure that we can identify. Now, we do know that sometimes high blood pressure can occur as a result of an underlying disorder of the kidneys. We do know that obesity, a sedentary lifestyle, stress, smoking, and excessive amounts of alcohol or sodium in the diet seem to play a role in the development of high blood pressure in people who have an inherited tendency to develop it. In most people, high blood pressure causes no symptoms. They actually call it the silent killer because you have the high blood pressure, you have no signs and symptoms that you know of that are causing you to be sick, and then it's basically that high blood pressure is destroying your organs, and you don't realize that you're really sick until you end up having a stroke. Doctors make the diagnosis of hypertension after they measure the blood pressure on 2 or more occasions. They advise, people are advised to lose weight, stop smoking, and decrease the amounts of sodium and fat in their diet. If they are unable to lower their blood pressure by modifying their risk factors, then the patient will be given antihypertensive drugs. Now, to a lot of people, hypertension suggests that the person has excessive tension, nervousness, or stress. This is usually not the case. This is not the case at all. Sometimes you will get a client who has presented to you with signs and symptoms of hypertension. Here's a cute little thing here: dizziness, regular heartbeat, nausea, vomiting, fainting. They have fatigue on here. They have a picture that says low blood pressure. I think that's kind of referencing if a person normally always has high blood pressure and suddenly the blood pressure drops, they'll be very, very symptomatic. They use a stepped care approach to deal with someone who has hypertension issues. They do in the first step, it says smoking cessation, and we know we have to have a person quit smoking 100%. They can't just cut down on their cigarettes. They need to stop smoking. Weight reduction. We know that we have a lot of obesity in our country, and it's very difficult to lose weight, but we have options that we can do to help people, classes and things we can do to help people reduce their weight. We know that there is a sodium. We want to restrict people's sodium. Sodium is actually should be kept to less than 24 milligrams a day. A lot of times they recommend the DASH eating plan. That DASH eating plan is a diet plan you can pull up on your computer, and it gives you ideas how to eat a little better and how to lower your sodium. Alcohol restriction is helpful. We know that alcohol intake should not exceed 1 serving of liquor, wine, or beer for women per day, or 2 servings for men. Exercise, aerobic exercise of 30 to 45 minutes most days of the week is recommended. And if blood pressure ends up still being high, they will add a diuretic. They know that a low-fat diet can be helpful. You don't want to get rid of all the fat in your diet. You do need just a little bit in your diet. We know that stress control can also be helpful. They show the second step here to go on antihypertensive drugs. Now, we'll leave that discussion for pharm class. If the first there's actually different levels of the antihypertension meds. They'll put you on the first step of the antihypertensive meds, and if those are not effective, they will jump to a third step, which has more medications. And one thing that you should commit to memory and you'll need to know through your whole nursing career is what are risk factors for primary hypertension. Well, we have non-modifiable risk factors. And things that are non-modifiable are your age, your gender, your ethnicity or your race, your family history. But there are a lot of things that are modifiable. Modifiable risk factors: alcohol, cigarette smoking, diabetes, obesity, stress, elevated serum lipids, excess dietary sodium, and we know that lower socioeconomical status is also a risk factor for primary hypertension. Hypertension in African Americans. African Americans tend to have a higher incidence of hypertension than other groups. I also know that there's some those of Asian descent have a higher incidence of hypertension. They think that African Americans actually have a higher level of complications and mortality rates from hypertension. There's been a lot of discussion about that in journals. Some researchers think it's an economic issue, the cost of the medication. Some think it's dietary practices. Some think it's just access to health care. I actually read an article that talked about it was just a genetic tendency after years of eating food that was purified in salt. A person that was African American may have just a different tolerance to the medications than some other folks that take the same medication. I cannot stress enough, whether it be for pharmacology or med-surg, they're going to discuss with you about preventing falls for patients with orthostatic hypotension. And they're going to get specific now. Sometimes I get students out of fundamentals and I'll ask them what orthostatic hypertension is, and they'll go, well, it's when you're going to fall. You have to be very, very specific here how to prevent falls and how to measure blood pressures when you're looking for orthostatic hypertension. We want to make sure patients know this teaching. You rise slowly from a lying to a sitting position. You don't hold your breath. You sit for 1 minute before you stand. You stand slowly and hold on to a stable object. They want you to stand for a minute before you walk. When you're seated, flex and rotate your feet before you tend to stand. And when you walk, you don't turn your head or body abruptly. And if they feel unsteady or have lightheadedness or sudden dizziness, they need to be aware that they need to put their call light and let someone know. Some new medical terms that you should read about and be able to talk about I've got it listed under complications. The first term here is malignant hypertension, and that is defined as malignant hypertension is very high blood pressure that comes on suddenly and quickly. And a patient can also go into a hypertensive crisis, which is called a hypertensive emergency, and that is defined as a hypertensive crisis is a severe increase in blood pressure that can lead to a stroke. And we're talking numbers extremely high blood pressure here, the systolic being 180 or higher, or the bottom number being 120 or higher. And you know when these numbers are this high, you're going to be damaging your blood vessels. I thought this was really interesting, a complementary and alternative therapy. A grapeseed extract is considered an alternative medical treatment for hypertension, and it will also help decrease your cholesterol. I've also actually heard of garlic being used to decrease your cholesterol. Just to kind of wrap this up, complications of uncontrolled hypertension. Remember that hypertension is causing damage to arteries. It makes them less elastic. It puts an increased workload on your heart. This can cause an MI, a myocardial infarction. It can cause congestive heart failure. It can cause left ventricular hypertrophy. When you have hypertension, you have small vessel damage to your brain that can lead to what's called a TIA, which is what my parents called that a mini stroke. Hypertension can also cause damage to the small vessels of the kidneys and can lead to kidney failure. It also causes damage to the arteries of the eye that can lead to blindness. We're going to go on to two new terms, arteriosclerosis and atherosclerosis. They sometimes are used interchangeably, but actually to be specific, atherosclerosis is a specific type of arteriosclerosis. Arteriosclerosis is when the walls of the artery get thick and harden. Atherosclerosis is when there is thickening in the arterial wall, but it's being caused by a buildup of cholesterol plaques. And these two, either hardening and thickening of the arterial wall or a buildup of cholesterol plaques, can actually occur in any artery. They tend to occur in these four. They tend to occur in the abdominal aortic artery, your coronary artery, your popliteal artery, or your carotid artery. Let's talk a little bit about definitions, etiology, and how diabetes and hypertension play into this. We know that arteries are blood vessels that carry blood from your heart to the rest of your body. So we remember that they're lined by a thin layer of cells that's called the endothelium. The endothelium keeps the inside of your arteries smooth, and that's what keeps the blood flowing. So atherosclerosis begins with damage to that endothelium. Common causes of damage to the endothelium include high cholesterol, high blood pressure, inflammation, obesity, diabetes, and smoking. And this damage goes and causes plaque to build up along the wall of your arteries, particularly when bad cholesterol, or LDL, cross that damaged endothelium. It'll enter the wall of your artery, and your white blood cells kind of go down there to digest it, and over the years, that cholesterol and those extra cells become the plaque that sit on the wall of your artery. So this plaque is there. It creates a bump on your artery wall, and as the atherosclerosis gets worse, the bump gets bigger. When it gets big enough, it's going to create a blockage. So diabetes and hypertension, and a person with diabetes and high blood pressure is actually 4 times as likely to develop heart disease than someone that does not have either of these conditions. About 2/3 of adults with diabetes have blood pressure greater than 130/80, or they're using prescription antihypertensive drugs. Over time, the diabetes damages the small blood vessels in the body, causes the walls of the blood vessels to stiffen. This increases the pressure, which leads to the high blood pressure. Peripheral arterial disease, or PAD, is atherosclerosis of the extremities, and it is virtually always the lower extremities, and it ends up causing ischemia. Now, mild PAD may be asymptomatic, or it may cause something called intermittent claudication. Severe PAD may cause rest pain with skin atrophy, hair loss, cyanosis, ischemic ulcers, and gangrene. Diagnosis is by history, physical exam, and measurement of the ankle brachial index. Of this nice picture that I found, everyone calls it the 5 Ps. And it's your circulation assessment, and I need you to remember it forever because it's going to come up again when you talk about CAS care. And the 5 Ps are pain, pulse, pallor, paresthesia, and paralysis. And this has been around forever since I first went through nursing school. And the reason that they have this here is because if you're going to have somebody with peripheral arterial disease, this is what you're going to look for in their lower extremity. Do they have pain? Do they have a pulse down in that foot? What does the foot look like? Is it white? Does it have good color? Does it have good capillary refill? Paresthesia, look at, they show a little pin being touched on the end of this foot here. Can the person feel you touch their feet? Do they have paralysis? Can they move their feet? Can they feel you touching it? There's actually been recently in nursing journals and books, a 6P was added to this list, and I'm going to have you go and look that up in your book so I know that you're reading your textbook. Treatment for arterial occlusive disease or intermittent claudication. Believe it or not, exercise is the best treatment for someone with intermittent claudication. Walking vigorously for 20 minutes twice a day encourages the growth of collateral circulation. It actually reduces the severity of claudication in the majority of patients. They have to start out slow and work up to the 20 minutes. I will also say they need a lot of teaching. They need to know if they do start to have pain that they can sit down somewhere and rest until the pain goes away. Just a note on older adult care points. One of the signs and symptoms of PAD is hair loss on the leg. But hair loss is a natural occurrence with aging, as is thickening of the fingernails and toes. You can't just use those signs alone as reliable indicators of vascular problems. So I want you to think big here. You can actually have an arterial emboli. An arterial emboli would cause an acute occlusion of your artery. An emboli is most commonly caused by a thrombus that comes from atrial fibrillation. And we're going to talk about atrial fibrillation in a separate discussion because I want to show you what the EKG looks like for atrial fibrillation and talk about that particular issue. But remember, the atria is there and it's not really squeezing the blood out of the atria. It's kind of quivering. So how would you know if a patient had an emboli down in an artery? Well, the signs and symptoms of an emboli occlusion are called the 6 Ps. Pain, pulselessness, poikilothermia, pallor, paresthesis, and paralysis. I left this picture in the presentation here. It's a picture of cellulitis of the legs, and one of the main risk factors for cellulitis of the leg is a history of peripheral vascular disease. Also, peripheral arterial disease also increases the risk of developing a non-healing sore on the legs, and if it becomes severe, the sore will develop into an area of gangrene. Gangrene is dead tissue, and this person that has gangrene would ultimately require amputation of a foot or leg. Femoral popliteal bypass surgery. Some people call it a FemPop. It's a procedure used to treat femoral artery disease. It actually goes in and they bypass the block portion of the main artery in the leg using the piece of another blood vessel. This surgery is used to treat conditions that affect circulation, like intermittent claudication. We're going to talk about aneurysm. An aneurysm is a bulge in a blood vessel caused by a weakness in the blood vessel wall, usually where there's a branch in the blood vessel area. As the blood passes through the weakened blood vessel, the blood pressure can cause a small area to bulge outward like a balloon. Specifically, for this particular chapter, we're going to talk about an abdominal aortic aneurysm. Nursing management of an abdominal aortic aneurysm. So we know that an abdominal aortic aneurysm is an enlarged area in the lower part of the aorta. As you know, the aorta runs from the heart through the center of the chest, and it is the largest blood vessel in the body. So if it ruptures, if the aneurysm area ruptures, it is a life-threatening bleed, and most people die if it ruptures and they are unable to get care immediately. Depending on the size of the aneurysm and how fast it's growing, the treatment may vary from them watching it to sending you into emergency surgery. So you say, well, what are symptoms? What do you assess? Well, the big assessment thing to associate with this is a pulsation in the abdomen. The AAA, they call it AAA, abdominal aortic aneurysm. They kind of grow slowly, not a lot of noticeable symptoms. They're difficult to detect. Some of them may never rupture. Some of them start small and they stay small. Some grow large quickly over time. If a person has an enlarging abdominal aortic aneurysm, they might notice a deep, constant pain on the side of their belly, some sort of back pain. You can feel a pulsation near the belly button, like an extra heartbeat. Most of the abdominal aortic aneurysms occur in the part that's up towards the belly. Several things cause these AAAs. Hardening of the arteries, atherosclerosis, people who smoke, people with high blood pressure. Infection can come up in the aorta. Sometimes a person gets a bacterial or a fungal infection. If there is a tear in here at all, it is life-threatening. Somebody that I do know, the actor John Ritter was on a TV show. This is back sometime, I'm going to say 20 years ago, and he fell down, passed out, and they took him over. He had a ruptured abdominal aortic aneurysm, and they were unable to save him. He bled out of his aorta and died before they could do anything to help him. If there's a rupture, there's a sudden intense abdominal or back pain. People feel like they have a tearing sensation down in their chest. Their blood pressure drops off, their pulse goes up. If you do have an abdominal aortic aneurysm, you can also develop blood clots in that area. If that wall clot breaks loose and blocks a blood vessel in your body, you could have one of your major organs not get enough blood to it. Now I'm going to talk about 3 diseases that are based from arterial insufficiency. I want to talk about carotid occlusion, Buerger's disease, and Reynolds disease. So if you look at this picture, it's going to show a carotid occlusion. So you say, well, what am I looking at here? When you have a narrowing of the blood vessels in the neck that carry the blood from the heart to the brain, you get something called carotid artery stenosis. And this can be caused by cholesterol buildup, what as you know is atherosclerosis. You can get a blood clot in this area. It can actually travel up to your brain. You may have this occlusion in your carotid area present for a long time before you begin to get symptomatic. When you start to get symptomatic, you may have a stroke or a brief stroke-like attack. The treatment depends on severity. If they diagnose this occlusion in the carotid area, if they discover this condition as a result of a stroke or a stroke-like attack, they put you on cholesterol-lowering medications and blood thinners to improve the blood flow to the brain. If the narrowing is severe, they go in and they have a surgery where they open up the blood vessel. It's called a carotid endarterectomy. So artery is in there, and ectomy means removal. They basically cut your artery open and yank that plaque out of there. The second option that they have is they have a stent, and that's in this last picture on the right. The stent goes in there, and it's like a little netting thing here, and it opens up and it pushes the plaque up to open up the area. And these are serious surgeries. Anytime you go into the carotid artery, there's a risk of stroke, and they normally don't come back to a regular surgical floor. They go to some type of step-down unit. This picture is of someone who has Buerger's disease. Buerger's disease also has a really fancy name, thromboangiitis obliterans. It actually affects the blood vessels in the body, most commonly in the arms and legs. What happens is the blood vessels swell, they prevent blood flow, and then clots form. It leads to pain, tissue damage, and can lead to gangrene. So, how does this particular disease start? They think that it starts by causing your arteries to swell and the blood clots to form out in the peripheral and the blood vessels, restricting normal blood flow and preventing the blood from fully circulating. The tissue dies when it doesn't have enough nutrients. Almost 100% across the board, everyone who diagnosed with Buerger's disease smokes cigarettes or uses some other form of tobacco like chewing tobacco. Quitting all forms of tobacco is the only way to stop Buerger's disease. For someone who can't quit, amputation of all or part of one of their limbs is sometimes necessary. This picture shows Reynolds disease, and sometimes in my mind I have to keep Reynolds and Buerger's disease separate, but Reynolds syndrome or disease is a condition in which a person's fingers and sometimes toes turn blue and or white upon exposure to cold, and then they get bright red when they rewarm. These symptoms are caused by the constriction of the very small blood vessels in the hand and feet, and it can last for hours to seconds. It usually lasts about 15 minutes. There's some major nursing interventions for Reynolds disease. You have to teach the patient to protect their extremities and prevent injury. They should be taught to dress warmly when they're out in the cold. Clothing should be layered. They should have a hat and gloves. Warm socks over their feet. They should be taught to wear protective gloves when they reach into ovens and when they handle extremely cold items. They need to avoid any cold temperatures when possible. They need to manage stress and to not use tobacco. Caffeine intake should be limited. If appropriate, the patient should be referred to a smoking cessation program. One thing that I can tell you for sure, it is normal. I had a student who had Raynaud's, and she would come in and her fingers would be white when she also smoked. They would get white, and we would warm her up, and they kind of turned red when they're getting the blood flow back, and that is normal to be expected with this disease. And she was having a hard time quitting smoking, and she would go outside to smoke. You know how people do, and I'd say, is that your best choice? And she'd go, thank you for the lecture, but and then when she touched you, like she handed a paper to me one day, and I mean, when I say fingers are cold, I mean like ice, not just the usual shivering cold that we all have when we come in from the wintertime days. There is such a thing known as superficial thrombophlebitis. Superficial thrombophlebitis is an inflammation of a vein just under the skin, usually in the leg. There can also be just a small blood clot down there. This is usually not a serious thrombophlebitis. This condition usually settles itself down and goes away within 2 to 6 weeks. You often see the area a little bit red and a little bit warm. As long as the extremity away from the thrombophlebitis stays warm and has a good pulse, they'll normally let this kind of go away on its own. Deep vein thrombosis, they call that DVT, occurs when a blood clot or thrombus forms in one or more of the deep veins in your body, and this is usually down in your legs. A deep vein thrombosis causes leg pain or swelling, but I've also had patients have a DVT and they had no symptoms at all. So, well, how do you get a DVT? Well, you can get a DVT if you have certain medical conditions that affect how your blood clots. You can have a blood clot in your leg if you don't move for a long time. After you have surgery or you've been in an accident, or sometimes when you travel a long distance, or when you've been on bed rest. Now, a DVT can be very serious because the blood clot in your vein can break loose, travel through your bloodstream, and it'll come up and it'll get stuck in your lungs, blocking the blood flow to the lungs, and that's called a pulmonary embolism. But you can also have pulmonary embolism and never had evidence of a DVT. It happens. But when they occur together, DVT and pulmonary embolism occur together, they call this venous thromboembolism. They can always abbreviate it VTE. So what are symptoms of a DVT? Signs and symptoms can include swelling in the affected leg. Very rarely is there swelling in both legs. You can have pain in the leg. The pain often starts in the calf. It feels like cramping or soreness. Red or discolored skin on the leg. People have a feeling of warmth in the affected leg. If you touch it, it'll feel very, very warm. Then also, as I said, the DVT can occur without any noticeable symptoms. Pulmonary embolism, a patient, if they have a pulmonary embolism and you are caring for them, they will put their call light on and you go in there and they are suddenly just so rapidly short of breath and are what I call desatting, with their saturations dropping, and you will know, you will be putting on 100% oxygen and calling a doctor. You will know something's happened. You know, obviously, if people are at home and develop signs of a pulmonary embolism, they have to seek emergency help. So the pulmonary embolism signs, it'll be, like I said, a sudden shortness of breath, chest pain that worsens when they take a deep breath. They feel lightheaded or dizzy. If you take their pulse, it'll be very rapid. Breathing, very rapid, sometimes coughing up blood. So causes, anything preventing your blood from flowing or clotting normally can cause this. There sometimes is damage to a vein from surgery or trauma, and then inflammation sets in. There are some risk factors that increase your risk of a DVT. Risk factors are your age, being older than 60, sitting for long periods, like when you drive or fly, if your legs remain still for hours and you don't contract your calf muscles. There was a reporter who was stationed in the first Afghan war, and he was riding in one of the Humvees for a long time. He was a young man in his 40s, and when he got out, he died of a DVT. It went up to his lung, it broke loose, went up, he had a PE, and he died. And everyone was talking about it, but he had been sitting in the same position for hours, which would be equivalent to the prolonged bed rest. Let's see here. Pregnancy can do this. They increase it because pregnancy increases the pressure of the veins in your pelvis. Some people with inherited clotting disorders can be at risk. Birth control pills are known to cause a DVT, especially if you smoke. That's always a big thing to keep in mind. Being overweight or obese also is a problem, and anybody who smokes. Anybody with cancer, some forms of cancer do increase the substances in your blood that cause your blood to clot. Anybody with heart failure, inflammatory bowel disease, they're all at risk for a DVT. Here's a picture from one of the textbooks with a patient with a DVT. If you look at the right leg there, you can see the red discoloration. If you touch the leg, it would be warm. It may be compromised down in the pulse area. You'd have to get a good pedal pulse. You want to make sure you don't grab this leg in any way. We don't want to dislodge that clot. Let's talk about varicose veins. Varicose veins are enlarged, twisted veins. They can happen anywhere in the body. They are very common down in the legs. They're not really considered a serious medical condition. They can be very uncomfortable and it can lead to more serious problems. And because they are kind of very noticeable when you try to go out in the summer in a pair of shorts, they cause a lot of people to feel uncomfortable or embarrassed. They also have spider veins. They're kind of a milder type of a varicose vein. They're smaller and they often look like a little sunburst or a spider web. And they're like red or blue when you look at them. They can be found on the face and legs, but usually they're just under the skin. So, well, what causes varicose veins? They're caused by an increased blood pressure in the veins. The varicose veins happen near the surface of the skin, very superficial. The blood moves towards the heart by one-way valves in the veins, and when the valves become weakened or damaged, the blood can collect in the veins. The veins become enlarged. If you sit or stand for long periods, it causes the blood to pool in those leg veins, increasing the pressure. The veins stretch out from the increased pressure. There is some the treatment is normally nursing interventions that we do naturally: compression stockings, exercise, lose weight. There are some doctors who could do a therapy where they sclerose that vein and make it kind of go back and go smaller. There's also some review studies indicating that horse chestnut extract can help relieve the leg pain and heaviness in people who have varicose veins. I want to talk about the term and the disease process, chronic venous insufficiency. So let's just talk about pathophysiology. Your veins return blood to the heart from all your body's organs, and to reach the heart, the blood has to flow upward from the veins in your legs. So your calf muscles and the muscles in the feet have to be able to contract with each step and squeeze the veins and push the blood up. And to keep the blood going up towards the heart and not back down, there's some one-way valves in your legs. So chronic venous insufficiency occurs when these valves become damaged, allowing the blood to leak backward. The valve damage may occur as a result of aging, extended sitting or standing, or a combination with reduced mobility. And when the veins in the valves are weakened to the point where it is difficult for the blood to flow back up to the heart, the blood pressure in the veins is elevated, and it leads to chronic venous insufficiency. One of the symptoms of chronic venous insufficiency is a varicose vein, but there are other symptoms that make it more of a chronic issue, because you could just have varicose veins and not have any other symptoms, but you can have chronic venous insufficiency. You're going to get swelling in your lower legs, achiness or tiredness in your legs, new varicose veins that you did not have before, and you get a characteristic leathery looking skin down on your lower legs. You get a lot of flaking or itching skin on the lower legs or feet, and people start to get stasis ulcers, or what's called a venous stasis ulcer. If the chronic venous insufficiency isn't treated, the pressure and swelling increase, and the tiny little blood vessels down in the legs begin to burst. And when this happens, the overlying skin gets this reddish brownish color. It's very sensitive to being broken, and if it's bumped or scratched. and it causes a lot of local tissue inflammation. And that's the least thing that can happen. At worst, the ulcers open up and make sores down on the skin surface. And those skin ulcers are difficult to heal. They can become infected. If the infection is not controlled, it can spread to surrounding tissue and cause cellulitis. Chronic venous insufficiency is most often associated with varicose veins, which are twisted and large veins close to the surface that can occur almost anywhere. Here in this picture, you can see the characteristic skin changes in a patient with chronic venous insufficiency. The color comes from the little capillaries that are broken. So normally, if you get a cut or a scrape, your body's healing process starts working to close the wound, and in time that wound will heal. But some people get ulcers that don't heal well on their lower legs without proper treatment. So they're called venous ulcers, or venous stasis ulcers. Some causes of venous ulcers they're normally around the ankles. So some of the causes, they occur because of damage to the valves inside the leg veins. These valves open up. Can they control the blood pressure down there? They allow the pressure to drop when you walk. If the blood pressure inside your veins doesn't fall as you walk, the condition is called sustained venous hypertension. That increase in blood pressure causes ulcers to form mostly on the ankles. There can be other problems. Venous ulcers can also be caused by other problems in your leg veins, and most often was the varicose veins that we talked about. Chronic venous insufficiency, if your legs just can't pump the blood back up to your heart. And I will want to say about diabetes. Diabetes can be a chief cause of people having venous stasis ulcers. And as you know, as you've been working with patients, we see a lot of people with lower leg ulcers that we treat. And those ulcers can turn into a nightmare for a diabetic patient who already has poor blood flow. And here you can see a picture of a very good, a good-sized venous stasis ulcer, and it's down near the ankle area. And if you look here along the skin area, you can see the dark discoloration in the skin. This person has had some venous stasis issues for some time for that discoloration to be there.